So this is the three generations of the prosthetic wall. The earlier generation, we used to use this ball and cage prosthesis, which we no longer nowadays use, but we still continue to use the single disc wall, especially the Indian made Sri Chitra wall. And then we have this most common is used as St. Jude bi-leaflet wall. This is a single disc wall. You can see it has a single tilting disc and it has two orifices, one larger and one smaller orifices. And then this is a bi-leaflet wall, which has a two tilting disc. It has a central smaller orifice, well, two larger orifices. And this is the T images as well as color flow interrogation as well as 3D images of how a bi-leaflet wall is seen on in 3D. And as well as fluoro images, you can see the angle of the tilting disc. Now, in this, one more important thing which you need to remember, as this bi-leaflet wall has three orifices, the central orifice is usually smaller and that has a more average velocities than compared to the other two orifices. So you tend to overestimate those gradients if you take it from the central smaller orifice. These are the bioprosthetic wall variants, which is made from usually bovine or porcine, Medtronic Mosaic, Carpentier's Edwards Magna, and Medtronic Hancock 2. And these are again the T images, color flow interrogation, and 3D images, as well as color 3D images of how the bioprosthetic wall looks like in action. So what are the things to start with a comprehensive evaluation of the prosthetic heart wall? So the most important, even before you start evaluating the wall, it is imperative to know the date of the surgery, the type and size of the prosthetic heart wall used, height, weight and body surface area of the patient, BP, heart rhythm, reference EOA. Normally, every company for a particular number of wall gives you a reference EOA and also gives the expected gradients for that particular wall. And this is extremely handy to compare it with the present gradients. So this is bi-leaflet wall again. And these are the various things. You look for the motion of the cusp and occluder, disc opening angle, clot or pannus, rocking movements of the wall, and sieving ring dehiscence, as well as washing jets. Apart from it, you not only look at the wall, but you also look at the LV and the RV function, the LA and RA sizes, and other concomitant valvular diseases. And not to mention, do not forget to look for pH in this patient. Now, this is a T image of a bi-leaflet wall. And you can clearly see there are some washing jets. You need to differentiate it from the paravalvular leak depending upon the volume, which is usually quite less. It is transvalvular, that is intravalvular. It is very brief. It has a narrow vena contracta and they do not project far back into the LA. To look for bi-leaflet wall, especially mitral wall, or for that matter any wall, the practical aspect in T is to keep the wall in the center and scan it so that you have not missed any of these paravalvular leak in any of the area. So ideal thing is you look into 0, 10, 50, 60 and scan each and everything and look for if there is any paravalvular leak near the site. And then the best way would be to look at 3D image. And this is a 3D color flow interrogation to look for any paravalvular leak. Now let's come to the Doppler, which we commonly use. The E wave here is 1.2 meters per second, peak by mean was 1.6, and PHT, pressure time was 42 milliseconds. Now this wall was Onyx 25, while expected gradients were 11.5 plus or minus 3.8, mean 5.3 plus or minus. So these were well within the normal range. Now, the second important thing which we calculate while evaluating any wall is Doppler velocity index or DVI. Now, this is the most important thing which you need to calculate. How do you calculate in mitral wall? You take mitral wall VTI divided by LVOT VTI. So, it is 28 by 19 and in this the value has come to 1.47. The next when you calculate the EOA. So, that is like a wall area. So, how do you calculate that? Stroke volume divided by mitral wall VTI again. So in this case, it has come to 1.6. Now the company that has made this wall has given a reference EOA around 1.9 plus or minus 1.1. So it was around 0.8 to 3 centimeters square. So this is well within that range. So reference EOA minus measured EOA was around 0.3 centimeters. That is less than 1 standard deviation for that reference EOA. So now this is 2D echo of the bioprosthetic wall. And what are the things you look for the bioprosthetic? You look for leaflet thickening, for thrombosis, as well as look for early wall calcification, degeneration of the bioprosthetic wall. So what are the Doppler parameters you use for assessment of prosthetic wall? The E velocity usually has to be less than 2.2 meters per second, mean gradient of less than 5, PHT of less than 100, EOA of more than 2 centimeters square, and DVI of less than 2.3. So how to evaluate a patient of high prosthetic wall gradients? So what are the causes of it? Causes are hyperdynamic states like anemia, sepsis, tachycardia, PPM, clot or PANAS, bioprosthetic leaflet calcification, paraprosthetic regurgitations, and technical errors, and localized high central jet. So let's go one by one. This is prosthetic wall obstruction. This is a patient which had a clot in the prosthetic wall, and this is a transthoracic image. These are his gradients, 2.6 meters per second. Peak by mean was 26 by 16. PHT was 190 millisecond. DVI in this case was 3.5. EOA calculated was 0.72 centimeters square. So what are the parameters which you see for in flow dependent, which are flow dependent prosthetic wall obstruction? So E velocity of more than 2.5 meters per second, mean gradients of 10 mm of Hg, while mean gradient of more than 12 mm of Hg on stress echo, increased mean gradient of more than 5 millimeters above post-op or immediate post-op, increased mean gradient of more than 50% from the baseline. And these are these gradients which are affected by LA, LV function, compliance, and filling pressures. Now there are certain which are flow independent also. PHT of more than 130 to 200 millisecond. EOA of less than 1.5 centimeters per second, measured EOA less than reference EOA minus 2 standard deviation, reference EOA minus measured EOA of more than 0.35 centimeters square, and reduction in measured EOA from the baseline, and DVI of more than 2.5. And but this is not sacrosanct. There are caveats to it. PHT is unreliable, especially in tachycardia with ENA fusion and first degree AV block and reduced AV compliance. EOA at times can be unreliable, especially with associated AR. In that case, you can use RVOT stroke volume or MR. And in DVI can also be unreliable, especially in AR as well as atrial fibrillation, because you have taken a different mitral wall velocity and comparing it to a different LVOT velocity. You have to take both the velocities at same point of time. So this is an algorithm which tells us how to go about. The first important point in this algorithm is DVI. So always look for DVI. Any DVI more than 2.3, there is some abnormality there for sure. Now, if the E velocity is more than 2.2 and pressure half time is more than 100, you are most likely dealing with prosthetic wall obstruction. But if the E velocity is more than 2.2, but PHT is less than 100, chances are it is more of regurgitation rather than stenosis. Now, if the DVI is more than 3.3, but E velocity is less than 2.2, then it can be normal, or there can be even mitral regurgitation. Now, in both these cases are high risk and intermediate risk for TE. You should go ahead and do an TE. But when the DVI is less than 2.3 and E velocity is less than 2.2, you don't need to worry much. It's essentially normal. So it's basically dependent upon DVI, E wave, and PHT. These are the three parameters on which you have to look for. So this is a case of wall obstruction. You can clearly see there is a clot there. One of the disc is stuck. Only one disc is moving, and there is a lot of spontaneous contrast there. This is a 3D image showing the clot with the stuck disc there. And then it's not just the wall which is, the obstruction. The obstruction can be even degenerative wall. This is degenerative prosthetic wall. You can see a lot of calcification on this wall, on the leaflets as well as annulus there. So let's go with how to differentiate then between Pannus versus thrombus. So pannus normally has smaller mass fixed. It involves suturing. It is centripetal growth, comes from the LA wall, inside the wall, confined to the disc plane, and growth is beneath the disc. Thrombus is large globular mass, independent motion. Annular ring may be visible. Projection into LA on mitral prosthetic wall, and it has an mobile elements. And this is how the pannus looks like over the wall. It is a structure which is innovated over the wall, and it does not respect the suturing. It goes well beyond the wall. So this is the chronology in pannus. Minimum, it takes 12 months. Common, it is more than 5 years. Low INR has poor relationship. Location, mitral wall is more common than aortic wall. Impact of gradient, aortic wall, impact on gradient and wall area is more than the mitral wall. Thrombus, usually it is less than 1 year. If late, it is associated with pannus. In bioprosthetic wall, it is usually between 3 to 5 years. Low INR has strong relationship. Location, tricuspid wall is more common than mitral wall. Mitral wall and aortic wall are almost equal. Impact on gradient and wall area, mitral wall is more than the aortic wall. Echo density, pannus has more than 0.7 echo density. It is 100% specific for pannus. Thrombus has less than 0.4. While cardiac CT attenuation, pannus usually has 200 of HU, while thrombus has less than 200 of HU. Impact on disc motion, it may or may not be there in pannus, but it is definitely there in thrombus. Now let's come to the PPM. If the calculated EOA is less than reference EOA, then there is prosthetic stenosis. But if there is calculated EOA is almost equal to reference EOA, but index EOA is less, then you call it as a patient prosthetic mismatch. So in mitral wall, in non-obese people, a wall area of more than 1.2 is considered as mild. A wall area is 0.9 to 1.2 is considered moderate, and less than 0.9 is considered as severe PPM. While in obese individuals, mild is considered as 1, moderate 0.7 to 1, and severe is less than 0.75. Moderate PPM are accounted for 30 to 70%, while severe PPM are 2 to 10%. So how do you diagnose PPM? What are the various things? So you get normal EOA for the wall. Occludus disc leaflets shows normal mobility. Measured EOA is equal to reference EOA plus or minus 1 standard deviation. Reference EOA minus measured EOA has to be less than 0.25 centimeters square. Normal or increased DVI. Index EOA less than 1.2 centimeters per meter square. So these are the various things. Now what is the problem with the PPM? Usually they have very worse hemodynamics, less regression of LVH and pH, worse functional class, worse exercise capacity, worse quality of life, and more cardiac events. So PPM is not a very good thing to be there. Higher risk of structural wall deterioration. And this is especially common in Indian population because of a smaller annuli. So you have to be very much certain about it. And lower survival. Now let's come to the occult prosthetic MR. So what are the things which you see on an occult prosthetic MR? Pizza is on the LV side, turbulent color flow in the LA, E velocity is more than 1.5 to 2 meters per second, increased gradient of more than 5 mm of Hg, increased DVI, mechanical of more than 2.2, while bioprosthetic it is more than 2.6, and normal PHT. Now this is one of the important parameters which you should know. If you get a DVI of more than 2.2 or 2.3 and a PHT which is less than 100, then you should think of that you are probably missing out on some paravalvular leak or some associated MR. And increasing pH, dilated and hyperkinetic LV. So this is a patient with a paravalvular leak. You can see this. A leak is coming outside the sewing ring and going towards it. The wall is opening adequately, but there is a leak. Now this is a patient where E wave is 2.5 meters per second with paravalvular leak, while PHT is less than 60. You can see that. So this is a classical of paravalvular leaks where PHT is less, while E wave and DVI is usually more. This is another case with paraverbal. And most important thing you have to understand is, howsoever good 2D you do for paraverbal leak, you will not able to ascertain the amount of leak or the amount of area for paraverbal leak. It is only in 3D which will help you to assess exactly where is the leak and how much is the area, and can it be closed with an occluder or not. So 3D is of paramount importance, especially when you are dealing with paraverbal leaks. So what are the things which you see in severe paraprosthetic MR? What are usually the eccentric wall hugging jets? Pizza is around 52. So when you start getting a pizza at the same velocity which you are measuring, you usually tell that this is significant paraprosthetic leak. Circumferential with more than 30% involvement. Rocking and dehiscence movement where the circumferential involvement is more than 40%. Vena contracta width is more than 7 millimeters. 3D VC ratio is more than 40 mm. Pulmonary venous systolic blunting or reversal. Dense triangular CW MR. EROA of more than 40 mm square. Regurgitated volume of more than 60 ml. And regurgitated fraction of more than 50%. These are the important. These are the same thing for the severe MR. The same criteria you apply for the paraverbal leak. And LV and LA dilatation and hyperdynamic LV. Now let us come to the infective endocarditis. This is a patient of bioprosthetic wall, and it has a lot of vegetations over the wall. You can see this is a big vegetation there, and this is fairly common in diabetic patients, immunosuppressant patients, and especially on the bioprosthetic wall. So let us talk about it also. Sensitivity of T is 82%, while that of TT is 36%. Serial T is essential. You look for vegetations. There may be newer paraverbal leaks which are there. That should again give rise to suspicion that probably you're dealing with MR there. New bioprosthetic valvular regurgitation, annular abscesses and cavities, and prosthetic wall dehiscence. All these factors tells you that you're probably dealing with infective endocarditis. Now let's go to the aortic wall quickly. In aortic wall, what are the things which you have to look for? Peak by mean gradient expected and measured. EOA expected and measured. DVI, LVOT VTI divided by aortic wall VTI. Now this is important, remember this. In mitral wall, the DVI was mitral wall VTI divided by LVOT VTI. In aortic wall, it is LVOT VTI divided by aortic wall VTI. Then acceleration time, that's again a second important point. In mitral wall, there was PHT, here it is acceleration time. Old echo reported gradients, all INR values, visible clot and pannus on T, fluoroscopy. And now this is the important, in aortic wall. If the jet velocity is more than 3 meters per second, if the DVI is less than 0.25, and if the acceleration time is more than 100, that means you are definitely dealing with aortic wall stenosis. If the DVI is again less than 0.25, but if the PHT is, your acceleration time is coming less than 100, then probably you are inappropriate LV velocity. You are not taken the LV velocity properly. If the DVI is between 0.25 and 0.29, but if the acceleration time is 100, then again it is stenosis. So acceleration time is the most important aspect while dealing with aortic wall stenosis. And if DVI is more than 0.3, acceleration time less than 100, then this is normal prosthetic aortic wall. And these are the values for aortic wall PPM. Insignificant PPM if EOA is more than 0.85 centimeters per meter square. Moderate PPM when it is 0.65 to 0.85 centimeters per meter square. And severe PPM if it is less than 0.65 centimeters per meter square. Indian annuli are very small. At times you can even get 16 to 17 mm of LVOT diameter also. So in that case, it really, this fairly is common problem with us, and we should be quite aware of it. Now, before I conclude my talk, this is a small appeal. I invite you all to Echo India on 15 to 17. Please block your dates. We'll see you in Mumbai. It will be an academic feast, and we're looking forward to seeing you there. We have all national and international luminaries who will be taking part into this. So looking forward to welcoming you there. Thanks.